Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about sickle cell disease. When I left off last week, I was talking about the complications of sickle cell disease affecting the different organs in the human body. And I was at the level of the heart when I left off. And I'm going to continue talking about the heart and the effect that the sickle cell disease has on it a little bit more in this segment. I did to take a few seconds of your time to again mention to you this book that I wrote, The Best of Clinical Medicine for the 21st Century. This is my 22nd book. It's an amazing number of books that I've written so far. And it covers medicine really throughout the world. It has 110 chapters, 816 pages. You can, I'm sure, get a hold of it in your local public libraries. It has very important information. It is written in a way so that the general public will have no problem understanding it. So take a look at it. I'm sure you could find it online somewhere, as well as there are always a few copies available in my office. In any event, take a look at it. I hope you find it helpful. Now, the effect of sickle cell disease on the heart are many. Namely, because by necessity, the person who has sickle cell disease, which is really the sickle cells, had this misshaped, half-moon-shaped, banana-shaped cell that you see there. They don't live very long. They have to burst open, hemolyze as it were, and they release the content into the bloodstream. The most damaging content they release, of course, is the iron. And that iron ultimately finding itself accumulating in the wall of the heart and in other tissues as well, but in particular in the wall of the heart. Now, that then causes damage to the heart, resulting in enlargement of the heart. But that's the least of it. The worst of it is that the most effective treatment for people who have sickle cell disease is blood transfusion. And when you transfuse somebody chronically with blood, they're going to inevitably wind up with iron overload disease, because for every unit of blood you give an individual, you're giving them 250 milligrams of iron as well, because the unit of blood is 500 cc's. Half of that is iron. For every milliliter of blood, you got half milligram of iron. So over time, these individuals wind up with iron overload that affects tissues all over. Well, you say, well, what's so bad about the iron? Well, what's bad about the iron is that the iron, where it sits, it has to degrade by necessity. As the iron degrades, it releases what we call free radicals. And free radicals are very toxic to human tissue, period. They cause a lot of damage to the tissue. And these individuals wind up having all sorts of problems. It doesn't matter the disease that's causing them to be hemolyzed, to be transfused, frequently. That's what's going to happen. They wind up with iron secondary hemochromatosis, which is a very bad disease. The iron itself, in addition to causing the damage, they're releasing free radical. The iron, wherever it sits, it causes an inflammatory reaction. Because it causes an inflammatory reaction, it is of no value to the patient, because the patient cannot use it. You say, well, how so? Well, let me explain the science behind this. There's a protein that we have in our bloodstream called transferrin. Transferrin means to transfer. The transferrin protein has receptor site, that's like fingers, as it were, attached to it. It is those receptors that has to grab the iron to carry it through the bloodstream into the bone marrow to incorporate it inside the early red blood cells for us to make red blood cell, new one, 24/7. Problem is, because of the local inflammation that the iron causes, you now have an issue. The inflammation itself blocks, listen to this, the inflammation itself blocks the ability of the transferrin protein to grab the iron and take it over the threshold to carry it to the bone marrow. Can't do it because the inflammation is so intense. So there's a block. There's a block there. so the iron backs up. So people who have chronic inflammatory disease wind up with an elevated level of iron, which make the inflammation that they have worse because of what I just explained. Very complicated issue. There are ways of overcoming it. An individual who have high level of red blood cell count for other reasons, these people can be phlebotomized. You could remove iron from them. You could also chelate the iron by giving them chelation medication to prevent them urinate the iron out, blah, 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 blah. All this can be done. However, sickle cell anemia, there's people that are so anemic, we cannot phlebotomize them. And it is not the protocol to give them chelating agent either. That's left for people with thalassemias and other stuff like that, okay? So it's very complicated. So the heart suffers tremendously. The heart suffers because of the ischemia that develops as a result of the clogging up of the vessel by these misshaped cells. And in addition, the misshaped cell, as they adhere to the wall of the vessel, they cause a local inflammation. That local inflammation ultimately results in plaque formation, further narrowing the vessel. Okay, so that's what's happening. And when that happens, the person winds up with a heart attack, angina pectoris, and congestive heart failure, and cardiac dysrhythmia. So all you have to be is be a patient with sickle cell disease, live long enough, you're going to wind up with significant cardiac problem, heart problem, which is the same as cardiac problem that I just stated. So it's a very serious thing. It's a very, very bad disease because the disease goes everywhere. And it's not getting, the incidence is not getting smaller, it's getting bigger. Worldwide, you have 300 million folks with sickle cell trait. In this country, you have 3,600,000 people with sickle cell trait and 100,000 people with sickle cell disease, the SS type. In Nigeria, for instance, you have 4 million people with sickle cell disease. It's a worldwide disease, especially now we have intermarriages taking place all over the place, which is a great thing, by the way. And then you have people traveling all over the place. So this is no longer a disease just of black folks. This is multiracial disease now as well. Now, so that's the heart. Okay, now let's go to the lung. I'm going to go from organ to organ to tell you how bad they can be affected by sickle cell disease. Let's go to the lung. The lungs get affected most frequently because of pneumonia. Because people with sickle cell disease have difficulty with the immune system. Yes, partly because they have no spleen. If you have SS, you have no spleen. The spleen would have been destroyed because of the sickling phenomena from childhood up. There's no spleen. So once you have no spleen, you are prone to develop more infection. You say, well, how so? Well, the spleen produces certain material that are necessary to dissolve the capsules of certain bacteria, such as pneumococci, for instance. And because the spleen is not there, you lose that part of the immune system. That is why, as I'm sure you've heard, that we prophylax individuals who have sickle cell disease. We give them Novavax vaccination every 3 years or so. And then in addition to that, we prophylax them with penicillin, 250 milligrams 4 times per day, because the pneumococcal organism, which is the one that affects them the most, respond beautifully to penicillin. If they are allergic to penicillin, obviously there are other antibiotics such as erythromycin or Bactrim or whatever we could give them prophylactically. That's the rationale behind that. That's the rationale behind that. But that put aside, they have frequent pneumonia of all sorts of stuff. More viral infection, more fungal infection, because the immune system is pretty bad. Okay, so now that you have the immune system that is not functioning well, these people are prone to develop community-acquired pneumonia. And they have recurrent pneumonia that can damage, you can either die from it, and if they survive it, they can damage the lung. And then, so that's the infectious part of it. But there's more than that. There's a condition called pulmonary hypertension. Just about every individual with sickle cell disease suffers from pulmonary hypertension as a result of the damage that has occurred within the substance of the brain, of the lung, because of the sickling phenomena. And one of the things that they suffer the most from is pulmonary hypertension. You say, well, what does that do to them? Well, if you have pulmonary hypertension, then you wind up with right heart disease. That's right. We have the left heart, we have the right heart. Then once you wind up with right heart disease, then you wind up with, again, right heart congestive heart failure, with legs that are all swollen, abdomen that are all swollen. Those are all signs of right heart disease, etc. The same cardiac arrhythmias, all this. So you have, basically they have biventricular disease. Okay? People who have coronary artery disease are likely to have left heart disease, and the right heart is functioning reasonably well. But when you have sickle cell anemia, you wind up with biventricular disease for two separate reasons. One, the right heart disease because of the pulmonary hypertension I just mentioned, the left heart disease because of the clogging up of the vessel by the sickle cell, resulting in ischemic disease. So they have bilateral heart disease. So you got your handful when you're taking care of somebody who has sickle cell disease, and they live long enough. I happen to have a lot of older folks in my practice because I've been practicing for 42 years, and 37 of those years have been private practice. And in the beginning of my practice, I used to have a lot of sickle cell patients. I had to back off from some of that because they were killing me. I was up all day, all night admitting people, so I back off. But I wind up with some of them that are still in my practice that are doing extremely well. I have some 76, 75, 72, 74 folk in my practice. And it will amaze you that I have people in my practice who have sickle cell disease that I have not transfused in 10, 15 years. I managed to treat them in such a way so that the hemoglobin and hematocrit stays at a level based on the type of treatment I'm giving them that they don't need blood transfusion, and they're doing fine. I have people that I have not admitted to the hospital in 10, 15 years who have sickle cell disease under my care. Because I'm a pretty hands-on guy, very detailed. There's nothing that passes me by. I don't take anything for granted. There's no such thing, I'll do this tomorrow or the day after. No, that's not the way I do it. And every detail is very important to me, because most of the time, it's not the gross problem that will damage the patient permanently by way of dying. It's the so-called nuances and what other people will call minutiae. They're not at all. Those are key components that will really help to keep the patient alive if you know how to use them and for the benefit of the patient, etc. So the lungs takes a tremendous beating. Okay. Now, let's go to another organ, the gallbladder. If you have sickle cell disease, you live long enough, you're likely going to have your gallbladder taken out surgically sooner or later. Well, how so? Well, the red blood cells, these fellows, these bad guys that are like this, they don't live very long. They live between 10, 15, 20 days max. And when they burst open, they release iron, but they also release a lot of bilirubins, another bile product, this yellow-looking stuff, into the bloodstream, and direct bilirubin. Well, then they develop what's called bilirubin stone, gallstone. That's right. So it is inevitable. You have gallbladder, you have sickle cell disease, you're going to have gallbladder disease no matter what. Why? Because all this pigment that are being released into the bloodstream, you have stones that are formed as a result of the pileup of this pigment. So this individual wind up with gallbladder disease. So when they present to you with right upper quadrant pain in the abdomen, then you have to consider that they may be having a gallbladder attack. And the diagnosis cannot be missed. You may remember, this is a sickler. The immune system are not functioning very well. And the gallbladder can be infected very easily. And sometimes that is a tragedy, because if the gallbladder is infected, you miss that. You may wind up with gangrene of the gallbladder. That's right. Gangrene of the gallbladder and sepsis, and a whole lot of terrible things can happen to the patient. So you have to be paying close attention to this patient all the time to make sure that the gallbladder is okay. It's okay once a year to do an abdominal ultrasound to look at the gallbladder to make sure it's okay, what's going on. There's certain blood tests that we do, the lipase, the amylase, to make sure that these things are not elevated, which could be an indication the gallbladder is sick, etc. Now there's another organ that sits not too far from the gallbladder on the left side of the abdomen. That's the pancreas. The pancreas and the gallbladder are interconnected in a network of tubes, because you understand both the gallbladder has to secrete certain substance that we need in order to digest the food that we eat, in particular if the food has fat in it. That substance comes from the gallbladder. And we also have stuff that has to come from the gallbladder that's also secrete stuff. In addition to that, those two things find themselves through a network of tubes into the stomach, and then when we eat certain food, in order for the food to be digested, it's just like when you have a plate in your sink that has grease in it, you could put all the water on that plate you want, the grease is not going away, it has to be dissolved. Well, the pancreas secretes the material that is necessary to dissolve the fat. Otherwise, all of us would be passing stool full of fat, and such disease, by the way, does occur, in particular in people who have chronic gallbladder disease for a variety of reasons. You have to understand the second cause of pancreatitis is gallstone. The first cause is alcohol abuse. The second cause is gallstone. That's right. The gallstone can get stuck in that network of tube. Those juices that we call them enzyme, but they are actually enzyme. I call them juice, but the right term is the enzyme backs up toward the gallbladder, toward the pancreas, causing an inflammation, and you have acute pancreatitis because of the obstruction of the stone that originally resulted from this sickling. Remember, a whole host of other people have gallstone for a whole lot of other reasons, but sickler and other people who suffer from hemolytic disease, such as the thalassemias, have more prone to gallstone than anyone else because of the pigment that they are dumping into the bloodstream. We know, I know, and I teach the people the condition that predispose people more to the formation of gallstone. I'm not going to bore you with that. Believe me, I know that stuff cold. But the point I'm making to you is that, okay, so when people come in with left upper abdominal pain, you got two things to worry about. If they have SS, you don't have to worry about the spleen. That's already taken care of by nature. However, you have the pancreas there. On the other hand, if they have SC disease or they have sickle thalassemia, those people still have spleen. And if you have sickle cell trait, they still have spleen. So when they come in with left-sided pain, you got to think about acute pancreatitis, chronic pancreatitis, or infarction of the spleen, because the spleen can get infected. That's right. So the tests, these are the stuff we call differential diagnoses. Those things absolutely cannot be in the back of your head. They have to be in the front of your head all the time to think of. Because if you miss these things, by the time you realize that the patient had these things, it may be too late to save the patient. Because the patient is immunosuppressed to begin with. He or she cannot handle infection easily, because the body cannot fight the infection because the immune system is bad, is poor. So right-sided pain in the upper abdomen, you think of gallbladder disease. Left-sided pain, you think of pancreatic disease and or splenic disease if they have a spleen. That's the way we think. Other things can happen in the abdomen. I know that. Believe me. You could have a whole lot of other terrible problem happening to the abdomen. That's not what I'm talking about. I'm just making a point having to do specifically with sickle cell disease. Okay? So, we talk about the pancreas. So, we talk about the gallbladder. There are other organs in the body that will be affected by sickle cell disease as well. Okay, so let's take a look at the bowel. What can happen to the stomach, to the small bowel, to the large bowel? A whole lot of stuff. Because if you have chronic pancreatic disease, you're going to wind up lacking the enzyme that's necessary for you to absorb food in the small bowel, and you wind up with malabsorption. How about that? Because you cannot absorb the food if the food doesn't sit in the small bowel long enough for it to be processed, for it to be absorbed, what's going to absorb to remain healthy, because the food is passing through. It's passing through because the enzymes are not there to digest the food. It's going to ride through you. You're going to have diarrhea. Okay? So malabsorption is a problem because of chronic pancreatitis that may result from the fact that the patient has sickle cell disease. That's small bowel. These folks have a propensity of having terrible stomach problem as well. You have to remember, when these folks present to the hospital, many of them, they're bending and pain. Pain is throughout the joint, but they're also holding the abdomen. They can perforate an ulcer. And you got to be careful because, okay, so you're going to do a blood count, right? So you're going to look at the white count, and you're going to look at the hematocrit. You're going to look at the platelet. Keeping in mind, people with sickle cell disease have elevated white blood cell all the time by virtue of the hemolytic process that's going on, okay? So, how do you discern if the elevated white blood cell is due to an infection, that is, where the white blood cell to an infection, or is it part of the sickling phenomena, and or how do you do that? Well, okay, if you're willing, and I'll teach you a couple of things. Well, first thing, take a look, do a differential count. The differential count will tell you if the patient has an elevated level of segmented polys, and or, more important than that, if there's a shift to the left, namely younger white blood cell and the myelocytic family are finding themselves in quantity that is quite large in the circulation. Well, what's going on here? What's going on is because those cells, all of us, as we walk all along, we have those cells lining the wall of a large vessel, sitting there to protect us. But the young segmented polys, we call them band, they're really not that good to fight infection because you have to, the polys has to be mature enough to have granules, and the granule can suck up the bacteria inside and release the content to kill the bacteria. But the polys don't have, the band don't have granule yet, they're too young. However, they're running toward the site of the infection anyway to see what they can do to help, because that's the natural body response. They call that demargination. They demarginate from the wall of the vessel, they're dumping themselves into, because there's crisis, there's an infection. Well, you could use that information to help you to discern based on the level of the band, as opposed, because you could be fooled by the elevated segmented polys. You say, well, how so? I know I don't want to snow you too much with incredible academic information, but I'll make the point. When somebody is under stress from pain of sickle cell disease, the pain itself causes the release of adrenaline. So far, so good. So the release of adrenaline causes demargination of white blood cell from the wall of the vessel, causing the white blood cell to become elevated. It had nothing to do with an infection, just the stress. Whenever you're under stress, and how can you be in pain and don't be under stress? So if you're in pain, your adrenaline level is going to be high, epinephrine, high adrenaline. Because it is high every time your level of adrenaline is elevated, you're going to have an acute elevation of your white blood cell, the polys. You understand that? Because of demagination. You understand? So therefore, you must then find a way to discern whether this is an infection. Well, you could do blood cultures, you could do chest X-ray looking for pneumonia, you could check the urine looking for urine infection, and if you are really a smart doctor, you do a sedate. How about that? See, I just give you something to put in your back pocket. You do a sedate, because the sedate will only become elevated. Let me repeat that. If there's an inflammation or an infection. Has nothing to do with stress. How about that? Because it is a phase 2 reacting protein called fibrinogen that causes the sedate to react. So when you're trying to discern whether there's an occult infection that is obvious for everybody to see, or it's occult, you can't see it, you do a very cheap test that's over 100 years old. Very cheap, but extremely effective. You order a sedate. If the sedate comes back, the normal sedate is from 10 to 30. If the sedate comes back elevated, you got two possibilities. Either you have an inflammation or you have an acute infection. Okay? And if your clinical impression that this patient has an infection and your sedate is elevated, what do? You do the cultures and you start the patient empirically with antibiotic that you know will cover for multiple different types of infection and multiple different types of bugs, bacteria. You got broad spectrum antibiotic. You use your brain. That's what clinical medicine is to use your brain. It's an art. It's not a science. It is based on science that I'm describing to you, but the judgment is based on clinical. If you don't have it, that's none of my problem. Can't help you. Okay? That's your problem if you don't have that ability, the knowledge to know how to do these things. Okay? Listen, I'm going to stop here. Next week, I'll continue to talk more about sickle cell disease. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.